was diagnosed on August 8th, 2011. Everything we thought we knew changed on that day.
It feels like you're being left out.
It's a race against the clock, and we need an actual cure.
Good morning, good afternoon, and good evening, everyone. I'm Hui Kai, Head of Content Division at WuXi AppTec. And it's my pleasure to welcome you to the 8th episode in our Rare Disease webinar series. And today we'll be focusing on Duchenne muscular dystrophy, or DMD. DMD is a rare muscle disorder. DMD patients lose the ability to walk, feed themselves, breathe independently, and succumb to heart failure. Just 2 days ago, on September the 7th, we honored the World Duchenne Awareness Day. Each year, this day reminds us the importance of strengthening the global communities for the DMD patients and the importance of remaining steadfast in our efforts against this devastating disease. During the past several years, we have seen many great progress towards new medicines and better care for DMD patients. But there's so much more we can do together. Today's discussion will feature over 20 speakers worldwide, including patient families, patient advocates, clinicians, researchers, and drug developers. Through the unique perspectives, we hope to foster new thinking or advancing scientific breakthroughs and chart a clear path forward with collective strength. At WuXi AppTec, we believe that a healthy future is only possible when every one of us works together as a global community. Thank you for joining us today. Let's tune in.
Hello and welcome. I'm Pat Furlong, founder and president of Parent Project Muscular Dystrophy. PPMDs Mission is to end Duchenne. Our aim is to drive therapy development that will halt progression of Duchenne muscular dystrophy at every age and stage. Our focus is on impact, influence, and change. Impact includes investment in research and translational medicine from academia to companies. Impact translates into driving consensus on optimal care for all, publishing standards of care, referred to as care considerations, which are now translated into more than 50 languages, and developing models for care that will be accessible to all individuals diagnosed. PPMD's certified Duchenne care centers serve more than 5,000 patients in the United States and is being replicated across the world. Impact also includes the Duchenne Registry, created by PPMD over a decade ago. It includes more than 5,000 patients from around the world and is set up to integrate the electronic health record with patient-recorded data. The Duchenne Registry has recruited patients from nearly every single clinical trial to date and has enabled the development of both primary and secondary outcome measures for those clinical trials. Next is influence. Influence includes leveraging private and federal investments in research. 20 years ago, PPMD's U.S. advocacy efforts resulted in the Muscular Dystrophy Care Act. The result of our advocacy includes the NIH and Department of Defense investment in Duchenne. That investment is more than $600 million and served as a tipping point for industry interest in Duchenne. PPMD's investments have touched every single therapy in development. Influence means working in partnership with regulatory agencies. conducting preference studies to understand benefit risk assessment in Duchenne involving all stakeholders, and developing the first ever patient-initiated draft guidance for Duchenne muscular dystrophy for the FDA and for industry. And finally, change. Since the MD Care Act, the landscape has changed dramatically. The lifespan has increased by 10 years. The overall investment in Duchenne now exceeds $5 billion. We have more than 45 companies focused on Duchenne, gene therapy studies underway, validated biomarkers, and newborn screening programs. Today, there is light in this once very dark tunnel, and we see a bright future to end Duchenne.
Hello, my name is Deborah Miller. I'm the CEO and founder of CureToShins, an organization whose mission is our name, to cure Duchenne muscular dystrophy. My husband and I started CureToShins 18 years ago when our son Håkan was diagnosed with Duchenne. There was little hope at that point. Today, Håkan is a journalist and doing very well for a young man with Duchenne. But it's not easy for him or for our family. We're dedicated to bringing treatments and a cure for everyone touched by this disease. CureToShins has funded many of the research projects that will be discussed on this webinar. We focus on innovative and impactful research leading towards clinical trials. We work closely with biotech companies and bring the best science forward. CureToShins Cares is a program that puts individuals living with Duchenne and their families first by delivering education, physical therapy training, connections with other Duchenne families, and introductions to the best clinical care available. CureToShins Link is an integrated biobank that connects actual biosamples to patient-reported data, as well as medical records. Having one identifier for a patient across these different data sources allows researchers and clinicians to gain broad understanding of all patient data. All of our programs work together to provide a comprehensive solution to the challenges of our community. We will continue working with a sense of urgency to bring the best care and best treatments to all of our loved ones with Duchenne.
I didn't know anything about Duchenne. Luca, my first son, was born in 1990 and he was 3 years old when we received the diagnosis of Duchenne muscular dystrophy. That was an earthquake. I started to work day and night to understand what was happening around the world. Then I came across a lady called Pat Furlong in the States. That was 1994. We started talking about what we could do for other boys with Duchenne and their families. And she inspired me to set up the PAN project in Italy because no one deserved to be left alone with a diagnosis like we were. We started like with just 2 or 3 families in Italy, and today there are 900 of us. Our last conference in Rome brought together 600 people from 34 countries worldwide. Together with academic researchers and companies presented their latest studies. Our journey has been an incredible experience. It has changed my life and Luca's life. And I think it has had the same impact on other people too. Many new drug treatments are coming to approval and we have many new options. Nevertheless, the need for a powerful patient advocacy of boys in research, treatment options and early and appropriate access to new therapies is more significant than ever. As patients and families, we need to participate in generating the data and discussing how the data is reviewed. We need to persuade the regulatory agency to involve us more because measuring efficacy in rare disease is hard to do and time is essential for patients and their families.
杜氏肌营养不良是一种基于基因遗传和突变而形成的儿童罕见病。这个在19世纪末被发现的神经肌肉疾病仍然处于无法治愈的状态。3500%的男性婴儿发病率和20岁左右因心力衰竭而死亡的困境，使杜氏肌营养不良成为罕见病中的常见病和给病患家庭带去无限痛苦的疾病。由社会爱心人士、企业家和医学专家于2012年创立的上海慈善基金会 DMD 专项基金和上海结癌疾病关爱中心一直致力于 DMD 的诊疗、康复、咨询、社会关爱、宣传教育与普及、国际医学成果转化、医学社会科学研究、中国罕见病立法和社会公共政策改进、DMD 图书编辑和出版等工作，并以病患管理和数据库建设为抓手，积极支持相关检测、药物和辅具开发机构开展携带者筛查、自然病史研究、临床试验、智能辅具开发等事务。我们期待与更多的国内外机构 开展更广泛的合作，为增进 DMD 患者的福利而不懈努力。
Little Steps was founded in 2010 by parents of children with Duchenne and Becker muscular dystrophy with a mission to improve their life quality and extend their life expectancy. We believe in a holistic approach that promotes patients and their entire family that surrounds and supports them. Little Steps provide services for the patient and their entire family members throughout all circles of life and all aspects of the disease. Information, treatments, medical condition, research, regulation, and emotional support due to the massive impact that the illness routines has on everyone. We are truly grateful for your partnership and support in our efforts. Thank you very much.
I'm Sharina Loh, co-founder and director of MDAS. Founded in 2000, MDAS provides care and support to people with muscular dystrophy, including Duchenne muscular dystrophy, or DMD. DMD is a debilitating and life-limiting condition that causes severe disabilities. This adversely affects self-esteem and life opportunities. MDAS advocates for inclusion and integration that empowers our members to overcome adversities. We educate and raise awareness to help families cope with the ever-changing challenges. Assistive technology opens doors to those with severe DMD. It becomes easier to find jobs now that COVID has opened the minds of the industries to work from home. It's also not all work and no play. Sports is important, and we have seen improvements in the overall wellness of our boccia and power soccer players. Knowing that they can excel motivates them. Constant medical intervention prolongs quality of life of DMD. Our oldest living DMD is 33. He lives a fulfilling life despite he's fully dependent on a BiPAP machine. Having benefited from MDAS, he became our ambassador and continues to raise awareness of MD. MDAS hopes that through a closer global network, we can further improve the quality of life of DMD communities around the world. It is not about how long we live, but how fully we live our lives.
It takes decades for a promising candidate to be developed for use in clinical practice. Unfortunately, with rare diseases such as DMD, we always knew there would be tougher challenges to overcome. For our first session, we invited leading DMD clinicians to discuss therapies used to treat patients today, approaches to early diagnosis and treatment, and the future of newborn screening. Our moderator is Håkan Miller, who is a DMD patient, as well as a featured writer for BioNews, where he tells stories about people making a difference in the rare disease community. As a DMD patient, he also has firsthand insight into living with this devastating disease.
Hello, everyone. Welcome to the WuXi AppTec Charting the Path for New Therapeutics and Better Care clinical panel. And I'm happy to welcome Dr. Richard Parra, Dr. Stanley Nelson, Dr. Kevin Flanagan. Thank you guys so much for your time, and I'm looking forward to the conversation.
Thank you.
All right, perfect. So I'm going to, just jump right into it. This is for you, Dr. Nelson. Right now, there are 5 FDA approved drugs for Duchenne muscular dystrophy. And so why don't you tell me a little bit about the impact of having that many drug approvals in the process by the FDA at this point?
Sure. It's been a seminal shift in the Duchenne field to actually have any FDA approved drugs. And it's only been since late 2016, the very first drug was approved. So all 5 of these have occurred in reasonably recent history. And, it's a steroid, it's 4 mutation-specific exon skipping drugs. And we now have these in our armamentarium for treating Duchenne. Not all patients with Duchenne, but a sizable fraction of those patients with Duchenne. And it's already begging the questions about how do we combine these? When do we start? when should we start an exon skipping drug? And many of us would feel that that should be as young as possible. There's an open discussion of when and how young to start steroid therapy. And many of us feel younger the better, since the disease process is already present at birth. There's no reason not to start trying to mute it as best we can. So, to me, what this indicates is we're heading towards a world where we will be having a multitude of different therapeutics, both mutation-specific and mutation-independent, and we will be figuring out how to use these things in combination to slow the disease and hopefully halt the disease, and in an ideal world, reverse the disease for many of those that are far progressed along the disease course.
Yeah, that's really interesting. Dr. Flanagan, Dr. Parr, do you have any other things to add, about that, when we should start diagnosing and I guess treating the patients with these drugs, as far as timing? Anything else you wanted to add?
Well, newborns are a particularly vulnerable group that make both the FDA and I think many physicians a little nervous, because newborns don't necessarily act the way older children do in response to a drug, and children don't necessarily respond the same way as adults. So it gets to be very hard to move therapies that get developed and tested in clinical trials in adults and older children down into the newborn group. So I think there's a challenge there, and it would of course be helpful to be able to detect early groups so that they could be studied more carefully to look at safety and best combinations or individual treatments. But how to do that is a little unclear. Well, I know we'll get into newborn screening a little more, but I think Dr. Nelson and Flanagan have some challenges to moving these therapies down into the very young ages, where clearly I totally agree that starting these therapies before injury is done would be the smartest thing to do.
I'll just add to that, if I could. I think there's really growing evidence that even small amounts of dystrophin expression do change the trajectory of disease over many years. So that's coming out of the treatment trials, but there's increasingly amounts of data from patient observations as well, unusual mutations that allow small amounts of dystrophin. So although I think many of us wouldn't necessarily call the 5 approved drugs kind of the home runs we're after yet, they do make a significant difference over time. The data clearly shows that. And I think it's, I agree with Stan's comment that I'm one of those people who agree with very early treatment with those therapies. And, I think the 5 things in the past 5 years tells us there is progress. There are other things in the pipeline that are promising, including other chemistries for exon skipping approaches and other exons being targeted. So the field is clearly moving, and we have to think carefully about how these issues of timing and the issues of newborn screening to optimize therapeutic onset.
Yeah, I would say, Hawken, just for practical ramifications, we do occasionally diagnose patients even without newborn screening around 1 to 1.5 years of age. And we have started exon skipping drugs at that relatively young age group, and have started particularly weekend only, not necessarily daily dosing of steroids, and particularly the specifically approved steroid for Duchenne in that young group. And we don't have decades of experience with this yet, though. So, but I think we're all reasonably pleased, but we may be pleased based on imperfect data at this point.
Right. It sounds like, to build data, you need time, right? And you have to, be a little bit patient in some cases with that. And I think all of you, including you, Dr. Nelson, mentioned, it's going to take a combination therapy. So, you have the steroid approved, exon skipping drugs approved. What would you guys like to see come out next that could really have a significant impact in in addition to what's already approved?
Well, I'll jump in to say I think the most promising at the moment is really gene therapies that'll deliver microdystrophin gene therapies that are in their best implementation will be mutation agnostic, are not dependent on the specific mutation. And we're fortunate now that there are well-designed trials from multiple different companies using slightly different versions of this, where we should get answers in the relatively near term about the benefit of this. That still leaves us, I think, with some challenges in that those are engineered versions of the protein. They're not, we don't have Becker muscular dystrophy patients, let's say, who are walking around with those exact proteins being expressed. We all expect benefit from them, and all the ones in trials show benefit in preclinical studies. We do have to see that data, though, to get a sense of how that is. But really, as an interim step, what we're all after is, of course, full-length dystrophin re-expression therapies. And there are some promising approaches on the horizon for that as well. But clearly, the near term is microdystrophin gene therapies is the most exciting approach.
And for right now, Håkan, they're driven by specific gene promoters. The AAV vectors that are delivering the genes are not getting to every cell that is missing dystrophin. So it's targeting a portion of the cells, but the major cell that's affected, mature myofibers are most dependent on a dystrophin being present. Do we need dystrophin? Would we benefit from dystrophin in satellite cells and the stem cells of muscles? Probably, and that would be a good, relevant sort of next generation. But I agree completely with Kevin that I think the disease is caused, it's a Mendelian disease that's caused by a lack of dystrophin from before birth, and replacing that in the key cells that are needed would be certainly a major step forward. It's probably not, I think we ought not be thinking of that as a cure. We ought to be thinking of that as a treatment, and because we're not going to be curing it, we're not going to be treating it in the cells from the very first step that it was occurring. We're always going to be treating it after the disease is already established. So I think we've got a lot of work to do. The part that I'd be excited about as well with that is recognizing that it's plausible to do it, that we can have AAV treatments, at least, if not other delivery vehicles, and replace with microdystrophin. What else do we need to do to change the muscle microenvironment? Is there a way to alter this? Muscle is very plastic. It absolutely changes over time. It changes during our lives. We replace our muscles, replace our satellite cells. Fibrosis can be reversed in theory. Immune response can be reversed in theory. What's that mixture of treatments that might be borrowed from the cancer field, from other fields that we might be using in the context of gene therapy to make gene therapy even more effective? So I think there's a lot that we'll be learning in this next decade.
Yeah, sounds very excited. I mean, there's so much that we will learn and that we can bring from other, disease communities. I think it's very interesting. So I'm going to move into newborn screening. We were talking about this a little bit earlier. I know this is Dr. Prad's specialty, but I wanted to ask you, what is the biggest factor that impacts successful clinical outcomes in Duchenne patients, and how does newborn screening factor into that?
Sure. I should qualify myself at the beginning as not a Duchenne clinician. I'm a neonatologist and a pediatric pulmonologist with mostly experience with cystic fibrosis, but there's been a very, I think, parallel story between Duchenne and CF. And speaking from my experience with cystic fibrosis, it was clear that the earlier the available therapies could be started on children, the better their outcomes were. I think that sort of makes common sense. May not be true for all diseases, but I think there's some evidence in Duchenne that would also be true. So how do you find children who are affected before, as early as possible, and before they have symptoms that may be irreversible? And newborn screening is certainly a principle that's been around for about 50 years and has been very successful from a public health standpoint in identifying many very rare disorders. There's sort of a set of rules that go along with it, which are you may put a disease into a newborn screening panel if there's a way to identify it fairly easily, that a laboratory could do the testing, and that there's a therapy available, which if started early would impact the outcome. And I think Duchenne now, as Dr. Nelson mentioned, since at least 5 years ago, would clearly fit into that category, because we know there's a test that can be easily done, and that's to measure CK levels in the bloodstream as at least a first tier test, and take those babies who have high levels to a second tier of testing that would be genetic testing, either probably sequencing of DMD that could be done on a population basis. And there have already been, I think, over 2 million children worldwide in various small trials that have shown that can be done successfully. So if we can identify children before they have symptoms, and we have therapies available that we can start very early, I think newborn screening is really where all the focus goes once the therapies are available. There are a group of patients already out there who have already escaped, and they're going to still have to be picked up as early as possible, trying to avoid the diagnostic odysseys that I know a lot of Duchenne families go through. But ultimately, if there is universal screening, and that would mean each of the 50 states in the United States, and each country makes its own decisions about whether or not to add a disease to the panel. If that can become fairly universal, so it's fair to everyone to be screened early, then you have a fairly healthy, normal-looking baby that is ready to receive a preventive therapy in a sense, maybe not a cure quite yet, but and then it also does help to have probably registries of to somehow keep track of these babies with cystic fibrosis. There's the advantage of having care centers and a nationwide database so that there can be sort of tracking of newly diagnosed patients, and what things are being tried for them, and what works and what doesn't. And I think that may also help speed up trying to identify the right combination of therapies to best improve outcome. Because if every center is isolated and sort of has their own experience, and it's not being shared or can't be analyzed in a scientific way, then some of the benefit of those experiences get lost.
Yeah, I think that's a great answer. And, for me, I also have Duchenne muscular dystrophy, and, I wasn't diagnosed until I was 5.5. And, thankfully my parents were right on it. But if they could have done that, 3-4 years earlier, who knows, the impact that could have. And I think that's common around all rare disease communities, that diagnostic odyssey, and newborn screening can fix that. So I wanted to follow up with you quickly. What are some challenges to newborn screening? And are there innovative approaches that you're looking at apart from the CK test that can help establish a diagnosis earlier?
Well, the challenges are the infrastructure. And as I said, 50 states in the United States each state will make their own decision. There is in the United States a federal commission under the Secretary of Health that establishes a sort of a guide for rare disorders to add to the newborn screening list that the states may then look to. So the goal for people interested in trying to get Duchenne screening on the books is to get some experience, bring it to that federal committee, get that committee to say, yes, we recommend this disorder to be added to each state's panel. And I think there's room for innovation in how to do the test. The CK test itself is maybe not very expensive, but the sequencing is expensive. And so I think there needs to be, if there could be advancements in high throughput sequencing for newborn screening, it's not unusual for it to take 5 to 10 years for a new disorder to be added to the newborn screening panel on a state. And that's why in the hospital I work in Massachusetts, in Boston, we sort of said, well, we're not going to wait that 5 or 10 years because the therapies are there and they're coming fast. So at least in our hospital, we've just started offering this screening to our pregnant mothers or mothers and fathers. And we decided we'd start in our hospital, see if other hospitals would be interested in doing that, and then gather some experience in our state, and then go to our state newborn screening program and say, look, we can do it. How would you like to take this over and incorporate it into mandated newborn screening for the state?
So going to Dr. Nelson, Dr. Flanagan, the Duchenne clinicians here, once you have that diagnosis at an early age, what's the best way to improve their outcome, and what do you need to learn more to figure out what you can do to improve that outcome?
Well, I'll jump in to say, as Stan mentioned earlier, there's a lot of interest in the idea of treating infants, treating younger children, even to infancy, with steroids. And although there's a limited amount, there is published data on the use of steroids in the youngest population. It's not of the class of data where we can say we clearly understand its effect. But there's sufficient longitudinal data to tell us the earlier we start steroid in patients, the better they do, the more bang we get for the buck. And many of us do use alternate regimens, including weekend dosing in the youngest population, to try to get some of the benefits of steroids without the same side effect profile of daily steroids, particularly in the youngest patients on growth, for example. We are a little off out of the best evidence-based medicine when we do that. We're off into some of the art of medicine, I would say, but there's a consensus among most clinics that see lots of patients in making those types of recommendations. I will say it's challenging because, it wasn't that long ago, it was perhaps 15 years ago, where less than half of the clinics in the country were using steroids for Duchenne. So moving that bar requires increasingly good trials, increasing publications of retrospective data. And I do think that bar is really kind of moving. I agree with Stan. We would use approved drugs like exon skipping in appropriate patients as early as we can. It's quite clear that we all understand we increase the side effect profile of steroids when we treat early like that. So we often have to make best kind of adjustments based on our own clinical experience. And I do think it's important for people to know that really very well-meaning people with lots of experience can differ on the details of what kind of regimens one might use in the youngest patients. But that there's a general agreement that earlier is better under most circumstances. So that would be the two things I think. Well, I'm sorry, let me add one thing. The other thing that early diagnosis allows us is to begin early interventions for those children who have cognitive impairment as part of their syndrome, or other developmental delays associated with dystrophinopathy. So I really think it's imperative to identify patients and get them into the sort of early intervention programs that can maximize their independent function.
Yeah, and I just echo several of Kevin's comments. I think there's a lot of reasons to sort of push for sort of team care very early on in Duchenne for a lot of these reasons. So in the neurocognitive area, certainly pushing for appropriate treatments, referring people to regional center. These are resources within every state that can provide lifelong resources to kids with substantial learning school issues for a subset of them. And those are better to recognize before age 3 than after age 3. And so we really do want to push for some of those things occurring much, much earlier. The other component is 2/3 of all of our families have no family history of Duchenne. It's either a de novo mutation, often in the mom, who then passes it on unbeknownst to her that she's a carrier, or it's a de novo mutation in the child. So there's no family experience with Duchenne. It's a genetic disease, but it's new in the family. And that's the vast majority of all the people that we see in every clinic. And that's how it's been for a couple decades. And so, it's, as your family knows, as every family, as you head into this, you develop a community, you really have to have a lifelong plan for how you're going to be combating this, how you're going to be living your life, what accommodations you might be looking for, both in how you're living, transporting, all sorts of issues that really play out across the family. And I think the sooner we can be giving people accurate, informed information, accurate guidance of what that looks like, and sort of the team to provide some guidance, the better off we are, not allowing people to sort of have to cobble together their own structures for those aspects, which are sometimes not medical. And then the others, of course, since they're often new mutations, we need to deal with the genetic consequences of that for risks for other children, other pregnancies, other females, and giving families guidance for a potential carrier female who's maybe only 3 or 4, who may or may not have some manifesting symptoms. Right. So there's a lot of proactive work that I think is actually very important, where, for instance, would be an individual who has a high CK will also have high liver enzymes. And often we see people getting liver function tests leading to liver biopsy without consideration that it's really a muscle disease. And actually, in our own look at UCLA records, that happens about over 10% of our diagnoses trickle into us that way through through basically hepatic evaluations, which are for naught. And Kevin, I suspect that's similar to yours. I don't think it's not an illness of our world here.
Right. We've never checked our numbers, but that experience is consistent with our clinic, certainly.
Yeah. And it happens at UCLA and it happens outside of UCLA. It's not a I got to the Mecca kind of a thing at all. It's just so I think we can prevent a lot of unnecessary odyssey, but a lot of unnecessary angst in other family members by getting into the heart of the matter and proactively providing that information to family members, particularly parents, but also maybe aunts, uncles, grandma, grandpa. It can go on for quite a while as we sort of figure out what it looks like in each family for how to help answer unresolved sort of questions, if you will. So we can often have the experience that when we diagnose a child, we also diagnose the mom as a carrier, and possibly even another adult who's much older, who's a male, who's affected as well, and just has never been realized to be that, but is at risk then of getting worked up for erroneous diseases. So,
yeah, I think, talking about getting earlier diagnosis, like it allows you to plan ahead with some of these things. Like you mentioned, we're going to need a wheelchair accessible car, when, he's 13 or 14, when he needs a wheelchair to get around. So those are questions. The more we know earlier, the easier we can plan ahead and prevent some of that angst, like you said.
Yeah.
So now I'm going more into, I guess, the genetic component. And my personal experience is that it's very difficult for me to get into a trial because of my phenotype, mixing my age and my 45 deletion. And I know I'm not the only one who faces the challenges of, trying to get into clinical trials. So Kevin, can you talk a little bit about some of the challenges for genotype, for drugs that are approved for a specific genotype that may leave out a large portion? Kind of what are your thoughts behind that?
Right. So that's we have, as Stan mentioned, 4 currently approved drugs that are genotype specific, and we know of other drugs that didn't reach approval that were, let's say, mutation class specific. And, it is a challenge that these leave the majority of patients without a potential treatment effect for it. there are many challenges with the current crop of those. And I want to be clear here that they've all been approved by the FDA. They've shown some measure of dystrophin expression or phenotypic improvement, although I think it's fair to say those are underwhelming responses in the sense of what we expected when these drugs first were came to, or what we saw in animal models, let's say, for comparison. So one challenge is managing expectations with these. Another challenge is getting them, at the same time, we know that most people who use them really are quite aware of the data that suggests with over time, there is a divergence in the course of disease with patients who receive these from patients who don't. And one challenge is actually in making sure that patients can get access to these. So although there's increasing data, for example, that exon skipping therapies improve particularly lung function and truncal function in patients who are treated with them once they've lost ambulation, I think these still show, I think, a lot of promise, and that's one thing we have to really recognize. The development of that class of therapies is not complete. There are other chemistries coming out. There are other methods of getting antisense oligos into cells that are going to be entering trials that show a significant amount of promise, and in fact have the potential to make more meaningful. They still have the potential to perhaps make more meaningful dystrophin expression than some of the other trials that are not mutation specific. So as an example, I would say that we know very much from looking at sets of Becker patients that the outcomes of exon 45 skipping for certain mutations are really compatible with ambulation long into adulthood, into 40s or 50s. Certain mutation classes that would be the outcome of exon 45 skipping could do that. And we can't say the same for every, I mentioned microdystrophin, for example. We can't say that for microdystrophin or other things. So we know what the outer limit of what lifelong expression of those versions of the protein should be, which gives us some idea of the function of the protein. And if we can boost expression via approaches like exon skipping, we have the opportunity to approach that outer limit of improvement. In the same way, certain mutations, as one example, single exon duplications, if that gives us a possibility where we can think about exon skipping approaches, really specific things, really specific therapies that are mutation specific that can get us to full-length dystrophin expression. So there's still real promise for mutation-specific therapies. They are not going to be available for all patients, that's true, but they, I think, hold really significant promise.
Okay, great. And I want to get to our last question, just thinking of time here, but this is kind of for all of you. I'll start with Dr. Prad here, but what are the biggest issues that keep you up at night in terms of patient care, those diagnostic tools and finding new treatments? What are you thinking about, in the middle of the night when you can't sleep?
Well, my fears are a little bit removed from patient care. They're more about how I can keep my screening program funded and running, because currently it's kind of it's running on a grant. My fear right now is keeping this going, but we're going to do it as long as we can until everyone else sees the light.
So it's open to Dr. Nelson, Dr. Flanagan, in terms of patient care and new treatments. Go ahead.
Yeah, so I sort of think about things at both ends of the spectrum. Both the earlier diagnoses and rolling out some of these, new, actually rather dramatic, even though not as effective as we'd like so far, therapies. Having a robust clinical trials pipeline that everybody who wants to be on a trial can be on a trial, and then broadening what those trials look like so that we can explore combinations. And that will be absolutely key to how we move forward into this next generation of therapeutics. And then the part that keeps me up quite a bit is, how do we roll many of these things out to those that have, we've managed to care for them for decades, but with substantial loss of muscle function. So our medical abilities to care for patients with Duchenne have been increased dramatically over the course of decades. And can we bring some of these therapies in a meaningful way to them to repair, modify the microenvironment, replace muscle, those sorts of issues, which are going to be a huge issue for the generation that's already here.
Well, I guess I'm sitting thinking about what keeps me up at night. Maybe there's two things. One is sort of related to mechanisms of some of the newer therapies. We don't know yet about the durability of gene therapies. We're going to learn that question, and that's always in the back of our mind. How are we going to handle retreatment? How will we handle this? And same question with how do we consider treatment with patients who have environmental exposure to AAVs, for example. But those are questions that are being worked on. There's a broader thing that keeps me up quite a bit, which is actually about disparities in access to, not only to the new therapies we're talking about, but just disparities to access for proper care for Duchenne dystrophy. We have to recognize that that those exist, and it's increasingly something that I know a lot of clinics are paying attention to. Why do our clinics not necessarily represent our communities, and who gets access to this care? What are the barriers to these highly these novel, these new therapies? What barriers exist in society, and how can we make sure they're equitably distributed?
Well, I think that's a great way to end our panel here. Thank you so much, Dr. Parra, Dr. Nelson, Dr. Flanagan, for your time. And thank you to our viewers for watching. I hope this was informative, and thank you so much for watching.
Thank you to our panel for that insightful discussion into the current and future states of DMD treatment and diagnosis. Our next session draws attention to adult patients with DMD and shares touching stories that bring hope to patients like Håkan worldwide. We would now like to welcome two very special guests: Håkan's mother, Deborah Miller, founder and CEO of CureToShins, and Pat Furlong, the founding president and CEO of Parent Project Muscular Dystrophy. Pat and Deborah will talk about the important role that the patient advocacy community plays in continuously raising the bar and catalyzing the development of the next generation of safe and effective medicines.
So how's Håkan? Good?
He's good. I don't have to tell you what anniversary milestones are like every year. So it's always tough, but fortunately, he's got his career. He's busy. He doesn't have a lot of time to think about it, and he just keeps going forward. But it's still a gut punch every day.
Yeah, it is. So many years after I lost my voice, it's still a gut punch. I think that you probably, as I do, we look at these young guys getting married, and not that they can't, but you want to be there, right? You want to steal a little piece of that joy. You want to see them succeed. Håkan's doing amazing things, but it is still a gut punch that he is losing strength, and I don't think we'll ever get over the gut punches. I just don't.
It's an interesting phenomenon that he's done well enough that he's been able to operate in kind of more of a normal situation, because he was, he's been ambulatory for so long. And so his frame of reference and comparators, because guys all compare themselves, right? Were normal, healthy kids. And now that's changing. And it's the hardest thing is to see the realization come over him that, yeah, he does really have Duchenne, right? And that he's following a path, albeit later, but it's still a path.
Yeah, I think that's right. I mean, I think that's one of the important things about Duchenne Action Month, as they've really focused on different things to focus on adults, because I think in the progression, regardless of whether you have slower, more rapid progression, there's a time when it must wash over you as a young man that this, in fact, is the progression you're going to see. And I've always wondered about how they feel inside their bodies. When this loss occurs, do they know it, or does it occur by symptoms, or how does it? So I really applaud you especially, and Håkan, and certainly your whole family, about encouraging independence, because I think that so many times we want to fully protect these young men and not let them experience friends, other people taking care of them, other activities, jobs, etc. So I think that's been amazing, and I really applaud all the work that you've done to make sure that Håkan is independent.
years ago, when Håkon was diagnosed 18 years ago, we were told, obviously, you know, like everybody is, go home, love your child, there's nothing you can do. And that you basically will be saying goodbye to him when he's 18. And all I could think of was this image of all of our friends going to their kids' graduations and going off to college, and that we would be standing at a gravesite. And I know, Pat, you've experienced that. And my heart goes out to you. It's, you know, as time is moving on, you know, there are these guys that are being in no way left behind, but not able to participate and see the benefit of all the hard work that you've done and that a lot of people have done. Just last night, I had a conversation with Håkon, and it was kind of this realization, you know, that he is going to need help. And I'm there with him, stretching him and realizing that I've spent 18 years working, and as you have, and there are approved drugs, and we've contributed to programs that are, you know, approved drugs now, and yet there's nothing for him at 24 years old. He doesn't qualify. He's never qualified for a clinical trial here in the US because of mutation or age. And it's just always been just a little bit out of grasp for him. And this is happening all over. And so I agree that, you know, as we look towards this upcoming month and we honor and celebrate the young men with Duchenne, I think just holding out hope that they can go to college, that they can have careers. And for Håkon, the next thing is girlfriend and marriage, right? So we just need to keep raising that bar for all of them.
I think that when we first really worked as a community on care considerations or standards of care, right, and those were international, that really demonstrated to us that we were able to apply known medical tools to improve and, well, delay progression with steroids and improve respiratory and cardiac, and certainly attention to the heart. I think with approved therapies, we're certainly bending that curve. I agree with you about clinical trials and opportunities for participation. Typically, as we both know, those clinical trials are not over the age of 18 often. There are one or two, but typically they focus on a much younger population. And again, I think moving this bar includes participation. It includes making sure that adults participate in clinical trials, that as we look at gene therapy and the hope for a delivery of a microdystrophin or some point later, CRISPR technologies, I think looking at this population to say, you know, you can halt progression at any time. And if you can do that, then life can really expand in terms of horizons. So I think that we as a community have to focus on that and move this bar on a continuous basis. And I agree with you and Paul that we keep pushing out this bar with known medical tools, appropriate care, the opportunity for clinical trials. I think who best to be able to tell us whether something is benefiting them. While I agree with outcome measures, I think that really looking at the quality of the life of Håkon and other adults will make us more able to measure the impact of therapies.
Yeah, there's a lot we can learn from a clinical trial with a different cohort, with an older cohort that perhaps is not used as a registration trial, but as a safety trial. Otherwise, we're going to have to go sequentially instead of in parallel to be able to find out in older patients whether these drugs and therapies are safe and effective. And I think we have the tools now to do that. It's basically the will to do that. And I think that will has to come from a lot of different stakeholders, whether obviously families are very motivated for this to happen, advocacy organizations like ours, regulators. The more flexible they can be and the more that they can actually encourage innovation to help patients that lie outside of the inclusion criteria is going to be very important.
Yeah, no, I think that it is time to stand up for these adults. It is time to make sure that they are included, to demand inclusion, not only in terms of appropriate care, but also in terms of access to these therapies and participation in the clinical trials that are relevant to them. I think that the best gift we can give them for their hard work to allow this whole field to build on their shoulders, the research that's been done, is to give them opportunities to participate and certainly to access the therapies once approved.
We also have some really exciting opportunities, maybe not tomorrow, but hopefully soon, with new therapies that are non-AAV based delivery mechanisms, which I think hopefully, if successful, could be transformational for older patients. Delivering a massive amount of AAV vector into an older patient is risky, no matter what immune modulation protocols you're using. So we've spent a lot of time talking and funding projects that are using non-viral delivery. The ultimate would be non-viral full-length dystrophin. And there are a lot of technologies out there that are quite interesting. And we're committed to seeing that happen and making sure not only can older patients be involved in this that might have the neutralizing antibodies, but also so far it looks like some of these therapies are not going to be durable forever and that they might need to be redosed. And therefore, the more we can fund and support programs where redosing for significant therapies is available, I think it's going to be very transformational also.
So I think trying to accelerate the pathways, not only in US, but worldwide, is going to be important. So looking at how do we get these approved? How do we get access to them? But you're right, if we could deliver a full-length dystrophin, if we could have better antisense therapies as we see second and third generation come forward, and one day CRISPR. So I think that there is so much hope on the horizon for patients with Duchenne and Becker muscular dystrophy. And I'm very hopeful that we can do trials that are very inclusive so that people don't have to wait long periods of time as we get the safety on these therapies, and certainly having a pathway forward to our approval. The boys need and deserve nothing less than our attention and our approach to therapies that is inclusive of them, regardless of age and stage.
Absolutely. We can't expect for a young man with Duchenne to actually improve upon a therapy, but if we can slow the progression, hopefully the ultimate would be even to maintain. So we need to be able to measure that. Regulators need to be able to understand how to measure maintenance or slowing progression. And I think that the more, again, that we can work together as a community to help them understand what's important to us is going to be really valuable moving forward.
Yeah, I don't think there's a family in the world that doesn't get up every morning and wish for this disease to stop, yes, right, to halt progression. And I think that we are really working forward to combination therapies, to therapies that will slow or stop progression, and certainly maybe one day the ability to build some muscle with some stem cell therapies as they come online. So I think there's a great deal of hope in this community, but I think we have to really concentrate on adults to be inclusive, because we can't, at the end of the day, say wait any longer. And we've been saying wait, it's not your time. We're going to focus on this younger generation because we have sensitive outcome measures. But I think it's time to say we have to focus on the entire cohort of patients with this diagnosis, from newborn screening through adulthood, so that we learn as much as we can and give as many opportunities for halting that progression as possible.
Absolutely. And in the meantime, we need to make their lives easier. And so, we're working with an organization that is trying to get airplanes to have wheelchair seating in there. And I mean, it seems like a natural, but the bureaucracy involved in it is tremendous. And so, again, working together to try and overcome some of this red tape, just to get the guys, the ability to travel and to be independent. I think there's a lot of ways, a lot of areas that haven't been touched that I think really need this attention now.
Yeah, I agree with that, Deborah. I think that there has to be policies in place, both not just in the airlines, but across, right? So the independence is really encouraged, and there's opportunities to live by yourself with carers, if that's what you would like to do. Opportunities to attend college, and not just local colleges, to go away and to have a caregiver or a set of carers that could be able to assist you going to class, taking notes, etc. I think you need independence in terms of employment, because many of these young men who are employed, and one day if we return to offices, that they will have a carer with them to assist with the personal needs that they may have, or transportation needs that they have, and policies that ensure that there isn't a threshold to whatever you make will maybe negate some of the services that you need. So I think that really independence, participation, opportunity, I think all of that is really essential for our adult men who can and should be successful, and should have opportunities to give you and I grandchildren, right? That's really the ultimate, as we see these young men grow up and grow old and then someday take care of us.
We compare ourselves, and I know that, between our two organizations, I think we should both be proud of the progress that we've made, but we've done it on a shoestring, and we've had to fight for every single success that we've had. And comparing to a large disease, whether it be cancer, heart disease, whatever, our resources are so scarce and so precious, and we have to fight together and not just work together, but like hustle together and make it happen and be able to be infectious with our sense of urgency to, not only our community, but outside our community to get people involved to help.
I think that making connections within the Duchenne communities, and we have a terrifically strong community in the US as well as worldwide, but outside, because some of these policies that need to change are generalizable, right? The wheelchair policy on airlines is not just a single Duchenne problem. So I think where we connect with each other, with outside of our organizations, and you're right, if we had extraordinary resources, but I think together we've done some extraordinary things. Now, if we can really continue that momentum going forward, I think we'll see the benefits of all that hard work. But it is true, the more resources you have doesn't necessarily change the timeline, but it sure does change the opportunities.
I believe we have momentum, much more than when I first met you, Pat, much more than even 10 years ago. And I think the pace of research, the pace of improvements are moving exponentially. So we just have to keep up that trend so that the guys that are with us today can continue to live really meaningful and healthy lives.
I think I agree with you. For new patients diagnosed today, it's a different day than it was 10 years ago, certainly much different than it was when my sons lived, when there was an empty field. So I think when I think back about that movie Field of Dreams, I think, together we've got this field of dreams. We just need to make sure that that field of dreams is full of hope and continues to advance so that one day a child will be diagnosed and they'll be treated instantly. And we'll see the fruits of that labor. But I agree with you. There's a great deal of hope and a great deal of comfort to say that we are on good paths with really a terrific field of people moving it forward.
It's hard to say when exactly it will happen, but I do believe there will be a cure for this disease. And I think that it will be manageable at some point. So we just need to make it happen sooner.
Yeah, I totally agree with you. One day soon. And that's what we're all hoping for.
DMD doesn't only affect patients. It sadly causes many families heartbreaking pain as they watch their loved ones struggle with the disease. We are incredibly humbled to share the story of the truly inspiring Nilsson family. Henry was diagnosed in 2011, and when the Nilsson family were faced with Henry's diagnoses, they made it their mission to make every day count, create lifelong memories, and live with hope, not fear. Let's meet this extraordinary family.
Henry is pretty much the light of the world for us.
Initially, Henry didn't really display any large red flags to us. It was little signals. Walked a little later, talked a little later. It wasn't that he didn't do those things, he just did those later.
As a parent of two kids, the first one, those are your milestones. You remember every time the child walked or talked. So if the first one walked at 9 months, he better walk at 9 months. And that was a little delayed with Henry. And the pediatrician said, well, he's got global delays and we'll do a blood test. And with that blood test was the worst news we could get as a parent.
Henry was diagnosed on August 8th, 2011. Everything we thought we knew changed on that day. Henry's starting to realize that this diagnosis is keeping him from doing the things he wants to do and his peers.
Is it sometimes hard to keep up on the playground?
It feels like you're being left out.
Sometimes it makes me frustrated knowing that we can't just go outside and play. It's okay. Because of his disease, he doesn't really like moving around a lot, so it's good for us just to sit and talk sometimes.
It was a gut-wrenching moment for my family, my wife and I. We both realized after crying for about 6 months, it's not going to stop us. We're going to pull ourselves up. We're going to find everything positive and go forward. Henry's extremely positive, and that rubs off on the entire family. He loves to figure things out. He'll build Legos by the hour. I don't care what Lego set there is, he can build it.
Why do you like Legos so much?
Because the can build anything.
Henry is very passionate about art and drawing, loves animation. His current goal is to be an animator for Pixar films.
I love that he's always cheerful and has a very optimistic outlook on things.
He's an amazing, joyful person. He can do anything he puts his mind to.
We learned early on that we didn't want to live under a cloud and under a shadow. And we wanted to raise our family with hope and optimism. And we celebrate every moment we get.
That's been the biggest thing with Duchenne. We don't put it off till tomorrow. We don't put it off till next year. We try to find a way to do it now.
The Cub Scouts and Boy Scouts have been a huge influence, and it's something that they find a way to adapt so that Henry can be involved and can join and can have fun. The silver lining in this diagnosis for us was to appreciate each and every day and to make a memory.
We're all very positive about it because there's actually steps being made. 30 years ago, if your son got the diagnosis of Duchenne, it was, go love him, he's not gonna live. Now there's hope.
It's like looking at an hourglass, and it makes it so much more time sensitive and crucial to get awareness for Duchenne and to raise funds for Duchenne, to get research funded and to get these treatments, and not just a treatment, we need an actual cure. For Henry and all the boys, it's a race against the clock, and the sooner we get it, the sooner we can save not just Henry, not just the young boys, but the older boys and all the future generations there are to come.
The sooner we find a better treatment, the sooner we have the power to save future generations affected by this tragic disease. We urgently need better treatment, as this is a race against the clock. We invite our next panel of leading clinical researchers to discuss how we can accelerate our search for new medicines that are accessible to DMD patients at a global scale. We will hear about the importance of development of drugs that are focused on the holistic needs of patients over the course of their lives, and clinical trials that cross geographic borders and encompass the diversity of patients that suffer from DMD.
Welcome to this session covering better, faster global development for DMD medicines. I'm Tim Franson from Faegre Drinker Consulting, your moderator for this panel. And having worked with this community for over 10 years, it's clear that despite several new therapies being approved for subsets of Duchenne patients, the broader unmet needs remain an urgent concern for many, especially for those at the extremes of age, progression, and secondary manifestations. The session title of Better, Faster Global Breakthroughs, or BFG, is reminiscent as a grandfather of Roald Dahl's children's classic BFG, The Big Friendly Giant, which can illustrate for us how some possible approaches for development improvements may be seen. The opportunities and barriers are big. Achieving progress in rare diseases requires more friendly data sharing, especially of things such as placebo arms, to speed common learning. And finally, even modest progress yields giant hope for patients. To guide us in these pursuits, we have three expert panelists with big friendly giant perspectives on better, faster global development approaches. Each panelist will introduce themselves and provide introductory comments about the subject, after which I will pose several questions for their responses. I now turn the program to Drs. Gomans, Clemens, and Binks with our thanks.
Hello, my name is Nathalie Gomans. I am a neuropediatrician by training, and I am affiliated to the University Hospitals in Leuven in Belgium. And I have devoted my career, which is more than 30 years, to the diagnosis and management of patients with Duchenne muscular dystrophy. But the last 2 decades have definitely been dominated by the work on translational and clinical research for the development of new therapies for this disease. And as you may know, there has been a lot of hope and expectations, and we've been thrilled by really exciting developments. But on the other hand, you are also well aware about the issues we have faced and deceptions and the disillusions that we have had so far. And so to me, with my experience as PI for clinical trials and therapy development, I see a number of issues that I really want to see, well, maybe not solved, but where I want to improve our insights. And I think one of the major things I've learned in the trial design for these diseases is to better understand the outcome measures that we are using, and also to better understand the natural history of the disease in order to better understand the results we get with new treatments. And to this end, as has been mentioned before, I think sharing data, pooling data is extremely important. And I still keep hope for these treatments, and I look forward to this discussion anyway. Thank you for involving me.
Hello, my name is Paula Clemens. I am a professor of neurology at the University of Pittsburgh in Pittsburgh, Pennsylvania in the United States. And I have also devoted my career to care and research for translational approaches to the care of Duchenne muscular dystrophy patients. It has really been clear that this has required a collaboration now extending over several decades between patient groups and patient support organizations, as well as academic groups and industry, to take us from a place where we had really no candidates for specific treatments for Duchenne to a place where there is really a robust research and evolving clinical care world. Speaking specifically to the collaboration needs, there have been, as I say, multiple partners involved. And one group that I have been very integrally involved with is the Collaborative International Neuromuscular Research Group, with the acronym Synergy, which is a collaboration of academic sites across the globe, which has banded together to do clinical trials in Duchenne muscular dystrophy, including both observational studies where we can identify and really hone in on some of the outcome measures that are really important for clinical drug development, as well as the drug development studies themselves. So I will conclude my comments there, but thank you very much.
Hi, I'm Mike Binks. I'm the Vice President of Clinical Research for Rare Diseases at Pfizer. I'm based in Cambridge, Massachusetts. I'm originally a UK-trained rheumatologist, not a neurologist, so I'm a specialist interloper here. However, for the last 10 years or so, I've been involved, 7 years or so, I've been involved in drug development for Duchenne muscular dystrophy, most recently with our gene therapy program. Across rare diseases, there are multiple challenges to try and develop new medicines and move them faster into the clinic and into regulatory approval. I've been incredibly impressed in Duchenne by the level of collaboration between academics in the sector, the companies who are developing drugs in the sector, and with patient advocacy groups. And the latter have impressed me beyond belief. The impact that they have managed to have generating support for education and and funding research, early research, helping companies to move into the space has been tremendous. And as Paul has referred to, the breadth of the portfolio in Duchenne now is very impressive. And it seems likely that we'll need to maintain that level of innovation in order to ensure that it's possible to deliver therapies for many different patients at different stages of disease. And you know, it's incredibly important that innovation is maintained. It's easy for us to forget in richer countries some of the challenges of getting access to medicines in other parts of the world. And I think that's what will be one of the topics that we'll be talking about. But clearly, particularly for advanced therapies, companies and academics and regulators are learning about how best to regulate these things. And I think that's a journey that we can all take part in, and patients and patient advocates can have a big impact on. So with that, I'll hand it back to Tim.
Well, thank you all very much, each and all. Very thought-provoking, and it leads us to some next steps in this discussion, especially when we talk about better and faster. It calls to mind that different approaches may be required. As you look at your respective experiences with Duchenne muscular dystrophy, thoughts please about the appropriate balance of benefit and risk measures. Several of you have mentioned new outcomes, and how patient-focused drug development may help us in terms of more insight into meaningful outcomes that make the most difference for patients. So Mike, let me call on you first for comments and then invite others to also speak.
So there's a lot wrapped up in that question. I mean, it's, again, with the gene therapy programs that are progressing, it's been very interesting to get the perspectives of patients and parents in terms of their perceptions around what will be acceptable in terms of a minimum benefit and what would be unacceptable in terms of a safety issue. And I think there's been some very elegant studies and there are more studies ongoing to evaluate the patient family preference in evaluating risk and benefit. So, you know, I don't think it's for physicians to decide, certainly not for companies to decide. I think it really is for patients and families in collaboration with the rest of the community, including regulators, to make these evaluations on risk and benefit. So I'll leave it there.
So maybe just to add to that, there are some unique aspects, I think, to some of the drug development that's happening in Duchenne specifically, in that number of the approaches are mutation specific or patient specific, and therefore not actually appropriate to do some of the testing that's normally done in drugs, where the drugs are given to healthy controls ahead of time. There are some disease modifying strategies that are in development where that could be done, but for instance, some of the exon skipping approaches could not be are done first in patient. So that requires a kind of a heightened attention to any risk. And, you know, clearly when patients and families participate in research, they are clearly hoping for some benefit, but always there's this sort of fine tension because these are research studies. And so whereas we would hope for benefit, we don't know that. If we knew that, we wouldn't need to do the research.
And may I add also about this risk-benefit assessment and the perception of the families that we have to, well, it's a terrible disease. It's a disease with a fatal outcome. So parents, when they get the diagnosis, they are first really, well, they would take really high risk for their child because and so I think for me well, having been an investigator for many years, I think it has always been very, very important how we go to the process of informed consent. And I think this is something that we have to stress to the families. Often it's like a whole bundle of pages with a lot of words. And I think as an investigator, going with them through all the explanations and making them really clear what they can expect, what we expect, what the risk can be for the families is extremely important. Also for the confidence, the relation of confidence between the physician, investigator, and the family. So I think this process of informed consent and being really objective and as transparent as possible about what we know. We have to say also that often we don't know everything, but I think describing all the risks and the possible benefits is very important.
Well, that brings to mind so many other interesting things. Thank you for each of your insights in that regard. And it certainly highlights that when one looks at benefit risk, can we view the continuum of Duchenne muscular dystrophy as more holistic, or do we need to get down to the skips and snips levels of the kind of genotypic versus phenotypic differences that we see, and how does that influence benefit risk in our assessments? Any thoughts in that regard? And I'll just throw it open. Paula, would you like to comment first and then others?
Sure. So I think, yeah, each drug development, one needs to look at where in the continuum of Duchenne care is it directed? Is it directed to the change at the DNA level? Is it directed to a change at messenger RNA level? Is it at a protein level? Is it downstream where you're looking at essentially muscle health? And so each one of those situations requires a specific approach and brings with it, different potential risks. And also really the potential that ultimately some therapies will be combined and maybe have an additive benefit by combining potential therapies.
Natalie, comments in that regard?
Well, I can only agree on what Paula has said still now, and I think that the development of drugs for the different genotypes is something that, well, is an area that's very exciting. But as Paula has mentioned, we need to be broader because there will always be this very specific gene mutation where we cannot target this specific mutation. And so trying to have a broad therapy development for the patients, targeting the different levels will be is for me still the future. Even if we can say we have something very specific for the gene, we will always need also other kind of therapies that target the downstream pathology. That's my opinion.
Very good. And Mike, any comments in this regard? This has certainly been a special interest of yours.
Well, obviously it's attractive to be bringing forward therapies that can be of benefit to a broad range of patients and are not necessarily genotype specific. But we have to keep an open mind as to whether particular genotypes are going to be more or less responsive, even though they may appear at first glance to be equally potentially beneficial. So, we're going to always have to look at these sorts of analyses in terms of who's responding well and who's responding not well or being suffering side effects or the safety things. So, you know, it's an important domain of variable that we need to ensure that we analyze thoroughly in our studies. And you know, I think most companies are doing that. It's very easy to do the genotype these days.
Well, points for us to consider from all of those comments. Certainly the proof's in the data, and we learn as we go forward, especially with new therapeutic options. And you've all emphasized or touched on the importance of understanding benefit expectations by both patients and regulators and tolerance for risk. So that certainly is a compelling area that we continue to have our minds on. It's very reminiscent of oncology and probably bridges to the next area where we may have lessons learned with oncology in the long term, as well as in global trials, as we find commonalities. You know, several of you have talked about collaborations without borders, which is very important. Can we think and delve into a little further what some of the opportunities and barriers are as we approach global trials, and how do we begin to find better and faster ways to conduct those? Natalie, you first.
Well, yes, I think this is a very, very important issue. And well, we are in a panel with people from the US and Europe, but I have also contacts with countries from what we call third world countries or others. And what we see is that they really want indeed to participate in clinical trials and to see how we can spread this. And to me, one of the most important issues first is to see how we can spread the message of standardized standards of where to standardize the care of the patients and to standardize the way how outcome measures are performed, because this is really the very first condition that I can imagine that companies would have to bring trials there. But this has been a message that I've heard so much through the TreatMD global registries from countries that where so far there are no clinical trials. So let's try to standardize the care first.
Great.
Yes. So I think it's important to remember that because Duchenne is a rare disease, it does require patient participation in trials across multiple countries, usually, certainly by the time one gets to phase 3 studies, which are typically larger and often the final step before regulatory approval. You know, Duchenne doesn't know any country barriers, and as far as we know, is equally has equal incidence and prevalence in all ethnicities. So one of the things that Natalie mentioned that I think is really key is really kind of the standard of care. And I think that the patient and physician community across the globe has done a really good job in Duchenne in terms of really trying to, you know, lift all the boats by lifting the level of the water, and so that I think the standards of care over the last 20 years have improved dramatically, and really across country borders, and that this is really important because you need a common entry point into studies to be able to put participants from multiple countries in the same study and get unified results.
Well put. Mike, additional?
Just that I agree absolutely in ensuring standardization of methodology and patient care is critical for the success of large global trials. And it does take a lot of time and investment and education and sharing to ensure that can happen. And you know, in preparing for our phase 3 programs, we've found that it's been really important to get involved early to ensure that there's a good line of communication and that there's a mutual understanding of what standard of care is and what even the clinical trial procedures need to look like, and to ensure that some of the laboratory work can be done and so on. So it certainly requires focus and investment to put on and to get to the point of well conducted, controlled clinical trials.
Well, thank you for all those insights. It's clear that standardization and common definitions, common practices, and outcome assessment training are all very important as we get into the nuances of capturing information about these very important patients. So one of the additional questions would be then, what barriers do we need to address as we get into further advances for better, faster development approaches? Are some of the challenges systemic, or are they more conceptual and scientific? How do we wrestle with all those things concurrently, understanding that the patient is waiting? So any of you care to take first foray with that?
Well, I can start. Yeah, I think really it's all of the above, right? We certainly can't stop innovating. There has been tremendous innovation in terms of developing really different approaches to potential treatments. But there are things in the pipeline, and that preclinical development is so critical, and one can't just think that that's done. That is definitely not done. I think one of the key barriers in virtually any treatment that we think about in Duchenne is the delivery barrier, and the fact that skeletal muscle tissue is throughout the body, and skeletal muscle is the primary place where the defect is in Duchenne, in the Duchenne disorder. And so any treatment has to get to skeletal muscle throughout the body. And I think that's, over really, more than 20 years, that has been the major issue. It is often not difficult to achieve amazing results right in the vicinity of where you insert the therapy into the muscle, but getting a delivery strategy that will get to all the muscle that needs to be treated, I think is a major hurdle that we need to address.
Thank you. Other thoughts?
Yeah, I mean, to this, there is indeed this sorry. There's indeed this problem of delivery to the muscles, but I think one of an additional issue is also, targeting muscles that are already diseased and advanced. And I think we have the voice of all these young men and adults that really want to have a treatment as well, which is absolutely understandable. And I think there we should also try to see how we can help them and see how we can have treatments that is beneficial for all patients in all stages of the disease, although all the expectations may be different from each stages of the disease. But I think thinking also of this group of patients is extremely important.
Very good. Mike?
In terms of developing medicines faster, I think that a huge amount of work has been done on characterizing clinical endpoints in longitudinal natural history studies. I do think there's still more work to be done there to characterize the progression of disease in different genetic populations and in biomarker development. But these have been very challenging areas. I think there's still scope for more movement with some of the digital technologies that are surrounding us all. I'm not sure we've fully exploited all the opportunities there. And the other area that I suggest was a systemic sort of barrier relates to working with global regulators and trying to get an equal understanding of regulators around the world of the severity of the disease and how the disease progresses and how to measure it, and the degree of unmet need, as well as getting standardization for some of the technical issues related to manufacturing of drugs and standardization across the globe. Each of those, the more standardization there is, the more global acceptance of regulatory standards, the faster medicines can be reviewed and approved globally.
Those are great thoughts as it relates to how we develop platforms of consensus and understanding. And your reference to several of you making reference to the differing regulatory bounds that may exist bring to mind the recent Olympics we all watched, and wondering how runners would do if they had one high hurdle followed by one low hurdle, by another high hurdle. It becomes very difficult. And how do we consolidate those? That's certainly perhaps a discussion for another day. But let me invite each of you to make any closing comments you wish about the ways forward. If you had a magic wand that you could change the development environment to make it better, faster, and more global, what would be that magic wand motion that you would make? So beginning with you, Natalie.
Well, thank you. So yeah, if I had a dream for Duchenne, I think I would hope that all the academics, the patient organizations, and the scientists and the companies would work together as they are doing now, I must say, but still there is improvement there. And I think that putting all the data together, trying to improve by this way our insight would be a great step forward. And at the end, I think, as has been mentioned, I see a future with combination therapies for these patients, boys and young adults, that would improve their quality of life.
Thank you so much. Paula, your comments?
Yeah, I think just recognizing that we're all in this together, and we all have a part to play, and each of us has a different part to play, and that's really, really important, and really to continue the collaboration that has started and has really only grown.
Thank you. And Mike, penultimate final words?
I very much hope that if we have this conversation in 10 years' time, there'll be another dozen therapies that are effective for one population or another in Duchenne. The things that I would like to change, I think, would be in relation to thinking further ahead to globalization and ensuring access to any therapies that are successful and that are transformational around the world. And I think there are sizable obstacles there, particularly with these complex advanced therapies, where even if they're progressed at cost, there will be affordability issues. So my main wish is that we have many more therapies available.
Excellent points. And just to provide some summary of things, in our aspirations to create better and faster medicines, you've certainly illuminated us with the thoughts of the importance of standardization, of common platforms, of collaboration, and of the hope of combination therapies. Those all strike us all as ways to really move forward creatively. And again, reminiscent of how other therapeutic areas have advanced. So in that spirit, I thank you all for those very thoughtful comments. And let me also thank you not only in terms of your big hearts and the way that you have, in a very friendly way, shared your experience with many of us who are less well steeped in this particular area or have not practiced there to the same degree as you have. And also the giant contributions you all make, not only to the education, but to what you're really doing at the patient level and those who ultimately suffer the ravages of the disease and also are enriched by the benefits of all of your work. So with that, I will say on behalf of our sponsors, thank you all for your contributions to the field now and ongoing, and especially to the patients. Best wishes.
There's a strong union of DMD patients, families, and advocacy groups around the world. Together with physicians, scientists, and drug developers, we are proud to say we are within reach of finding new therapeutics and better care. Once these new therapies have been found and developed, what are the next steps in our DMD journey? Our next guests from academia and industry will share their knowledge with us about the biological complexity of DMD and current and future approaches to find innovative medicines that address this.
So welcome to this webinar on Duchenne muscular dystrophy. I'm Rick Saul, and I am head of the Boston office. I'm a senior advisor for WuXi AppTec. And today's panel discussion will focus in on therapeutic approaches to Duchenne's muscular dystrophy. DMD is a rare degenerative muscle disorder that results in muscle and heart failure. The genetic basis of the disease, which occurs in boys, arises from mutations in the gene responsible for the dystrophin protein production, for which there are more than several thousand mutations, giving rise to a defective dystrophin protein. There's no known cures for DMD, so treatments that are focused on improving muscle strength and functions with corticosteroids, or treatments for DMD patients with specific DNA variants have allowed for shorter usable dystrophin. With 79 exons, the dystrophin gene is considered one of the largest genes in the human genome, and it's believed that the exon skipping technologies may be applicable to 60 to 80% of the Duchenne's patients. With me today are some of the key innovators involved in creating novel therapies directed to Duchenne. Jane Lockendale is the Vice President of Clinical Sciences at PepGen. Rhonda Bassel-Dubey is professor in the Department of Molecular Biology at the University of Texas Southwestern Medical Center. Art Levin is the Chief Scientific Officer at Avidity Biosciences. Ash Duger is Senior Vice President and Head of Medical Affairs at Dyne Therapeutics. And Stuart Peltz is its founder and Chief Executive Officer at PTC Therapeutics. So what I'd like to do today is to start off our discussions looking at modalities, what that means for the patients, drug development challenges in the Duchenne area and rare diseases in general, outstanding issues from the technical and drug development perspectives, and the impact of collaborative approaches, lessons learned and insights, and finally talk about some of the prospects on the horizon. So when we get started, let's discuss modalities and therapeutics first. And for that purpose, I'd like each of the panelists to describe first how transformative has the approved therapies been to date, where the gaps that exist, and how your technologies that are being pursued by your company or groups are addressing Duchenne. So what I'd like to do is start with Stu. Stu.
Yeah, thanks, Richard. Appreciate being here. So our company has been working in Duchenne muscular dystrophy now probably over 20 years, and we have two products in Duchenne muscular dystrophy. One product is to trick the cell to produce dystrophin protein in a particular body of patients who have a mutation called the nonsense mutation, and that's called Translarna. And then we have a second drug that we're commercializing in the United States, which is Inflaza, and that's a corticosteroid, because what happens is, the as you said, dystrophin, it's the loss of the dystrophin protein that results in the disease. And the consequence of that is that it's like a shock absorber. And so as muscles contract, you could see breakage of the muscle, and that leads to constant loss of muscle, but also inflammation. So the Translarna, about 15% of patients have a nonsense mutation, and that's like a point alteration that leads to premature production of the protein, and you don't have it. Translarna tricks the cellular machinery to allow the protein to read through and therefore to make a full-length protein. So that's being commercialized around the globe outside of the United States. So we're focusing on, they're both orally bioavailable molecules. One is to treat a subset of patients who have this particular mutation. The other is to treat the overall inflammatory response that occurs as a consequence of having muscle breakage. So those are the two products that we're working on. They're both orally bioavailable. So you take it as a pill or powder, and you take it orally, and again, it's systemically given.
Would you like to go next?
Sure. So many of the therapeutics another therapeutic approach which is being taken in Duchenne muscular dystrophy is the exon skipping approach. And much like Stuart's approach, you're trying to trick the cell or trick the molecular machinery in the cell to produce a shorter version of the dystrophin protein that's where you skip over a particular exon that may have a mutation in it. And existing therapies exist that use that mechanism, but the shortfall of those therapies and the reason that we are all here today is that it is difficult to get oligonucleotide therapeutics into muscle cells where they're needed for this disease. And what we've done at Avidity is we've taken an approach where we're using monoclonal antibodies to a cell surface protein that have been conjugated with an oligonucleotide specifically designed to skip specific exons for particular subsets of boys with Duchenne muscular dystrophy, and use that conjugate in order to facilitate the delivery of that oligonucleotide therapeutic into the cells. Now, this overcomes some of the barriers that have been developed, we've evolved with over the eons, and that is cells have evolved over eons not to take up foreign oligonucleotides. So you needed to come up with a molecular mechanism that allowed the cell to take up the oligo, and we're using monoclonal antibodies for that. Without that kind of approach, if you're not going to use a conjugate approach, it turns out that some of the oligonucleotides that are being used in therapeutic applications today have relatively poor pharmacokinetics. So if you can improve the pharmacokinetics, increase the amount, and then use receptor-mediated uptake to deliver the oligonucleotide to the cells where it's needed, you can actually create huge leaps in the potency of drugs that are pretty much on the market today, but have the ability to be even more potent if we can figure out a way to deliver them. So it's really taking an approach that addresses some of the delivery issues and really addresses eons worth of evolution where we've evolved, cells have evolved to prevent oligonucleotide, in general, foreign oligonucleotides entering in cells.
Thanks very much. Jane, could you tell us what's going on at PepGen in your approach?
Absolutely, and thank you for inviting me to join this panel. So our approach at PepGen is somewhat similar to what Art has just been talking about, because we also are looking at exon skipping therapies and oligonucleotides to attempt to address some of the people with Duchenne and specific mutations. The difference between our approach and what they're doing at Avidity and Dyne is instead of using an antibody or a fragment of an antibody to solve that issue of delivering oligonucleotides, we're using a peptide, so a small piece of protein that helps the oligonucleotide get across the cell membranes into the tissues of interest. We have a great deal of data showing we can get into muscle tissue, cardiac tissue, smooth muscle tissue, skeletal muscle tissue, and indeed a number of other tissues as well with what we've been developing. Our platform is really based on a huge amount of work that was done at the University of Oxford and the University of Cambridge over long periods of time, where they identified these peptides quite a long time ago, before the first exon skipping drugs were approved. But they did a great job of getting things in, but unfortunately they were toxic, and this is not a great thing if you're a patient. With a vast amount of work and medical chemistry has gone on, and now we have peptides that are both safe and very effective at getting drugs into cells, particularly muscle cells. And that's what we're working on. I think Art has said everything that needs to be said about the issue of delivery of oligonucleotides. These are incredibly potent therapies, but if you can't get them to where they work, they will not be as incredibly effective as we'd like them to be. And I think on this panel, we have several different approaches to how to solve that problem of delivery.
Ash, how's your approach to dyne differentiated from others?
Yeah, thank you again for inviting me to this great panel. I'm really excited about being here. So, I'll just emphasize one thing that both Art and Jane talked about first, that current exon skipping therapies, they're limited. And one of the limitations that is clear is their ability to get into certainly skeletal muscle in enough levels to create robust exon skipping and dystrophin production. But even penetration into cardiac tissue and diaphragm has been really limited with current therapies, although they definitely provide benefit to patients. But I think we all agree that delivery of exon skipping therapies to muscle is an absolutely key issue that we all are trying to solve in different ways. So, at Dyne, we have something called a FORCE platform. It essentially consists of 3 parts. One is a proprietary Fab antibody. So we use an antigen binding fragment or a piece of the monoclonal antibody that has a high affinity for something called a TFR1 receptor. It's a transferrin receptor that's highly expressed across muscle cells, skeletal, cardiac, and smooth muscle. And so with this high affinity binding to the TFR1 receptor, we're able to also make sure that we're linking our Fab to our exon skipping PMO to be able to drive the therapeutic payload, the PMO, into the muscle cells so that we can generate robust skipping and dystrophin production, and hopefully with limited, off-target effects. So, we're all trying to solve, a similar problem here. And it's great to see different technologies attempting to do so.
Terrific. Earlier is work going on at UT Southwestern, Rhonda. Maybe you can talk about some of the exciting work that's coming up from there.
Yes. Again, I want to thank you, Richard, for inviting me to be part of this panel. As you mentioned, I am working at an academic university, and we are taking a different approach from that which you have heard from the other panelists. We're actually going into the blueprint, into the genome, into the DNA, and modifying the actual mutation that in the dystrophin gene that causes the Duchenne muscular dystrophy. And we are using CRISPR, which is a gene editing tool that was first originally found in actually bacteria and now has been engineered to use in human cells. And so we are using that technology to correct the mutation and restore dystrophin expression as well as dystrophin function. So that's the approach we are taking.
Now, for each of your technologies, I would imagine there's a number of outstanding issues, technical issues that still have to be overcome. Maybe start with Art. Maybe you can talk about some of those issues, and then I'll let the floor be open. Thanks.
So again, the key issue is delivery.
Yeah.
And we're actually very close to starting our first clinical trials with another oligonucleotide therapeutic for another rare skeletal muscle disease, where we will learn whether or not using the transferrin receptor in humans allows for uptake into patient cells. So again, we're very close to being able to check off a box with respect to the delivery issue using this monoclonal antibody as a delivery mechanism. And then from there, we will immediately shift gears and begin our work in looking at exon 44 amenable skipping in DMD. So again, the delivery issue remains the issue of key critical importance. And hopefully in the very near future, as we're just about to kick off clinical trials with another transferrin-mediated uptake in a muscle disorder, myotonic dystrophy type 1, we will at least have a basis at this point in time for where we can leap off as we begin our programs in DMD.
So talking about challenges, I echo what Art said. The delivery, even with the CRISPR components, we face the same challenge in terms of delivery. We have chosen right now to use AAV, adeno-associated virus, to deliver the CRISPR components. And we're also playing around with some lipid nanoparticles. But you can imagine the task of getting these particles in all the muscle. So right now, viruses seem the best way for us to go. But it is a challenge, I agree.
And, you know, like many of us at different companies and institutions, you know, we're doing as much as we can to learn about our technologies. And so in order for us to be able to get to a place where we can have trials in patients, there's a tremendous amount of work we've done in relevant non-clinical models to help us understand how to optimize the delivery, you know, to help us continue to understand, you know, the right dose and dose frequency for our products. And so, you know, at Dyne, we've done a lot of work in sort of the traditional MDX mouse model to look at exon skipping, dystrophin, dystrophin production, function, as well as safety. And then, of course, we're doing studies in non-human primates where you can look at, you know, exposure and safety and skipping. You can't look at dystrophin, but, you know, you can look at exon skipping. So, you know, to be able to understand the technical limitations and to understand how best to enter into trials, you know, we're doing a lot of non-clinical work. And at Dyne, you know, we're close to getting into the clinic for 51 skip amenable patients, and then we'll follow it on with other patients with other mutations, and it applies to other disease areas like myotonic dystrophy or FSHD. So we're really excited about the technology, and we learn from one program to another. You know, everything builds upon itself, which is really important. You continue to learn about what your technology can do, what its limitations are, the safety, and so it's really important to accumulate learning across different models and across different therapeutic areas.
Yeah, and to add to that, Ash, I think in addition to learning about each of our own molecules, which are being delivered in different ways and have different toxicities, so we all have to do that work independently, there's so much we can learn communally as a field. Where are those oligos going once we deliver them? Are they getting into the cytoplasm? Are they getting into the nucleus? Where will they work best? How long do they last? Are there long-term consequences of having them in there? And as a community, as the science evolves, we're all learning so much more there. But then even when we get into the clinic, there are going to be more challenges of just the variable population and the changes in natural history and the differences in natural history between one group of patients and another, and people with one mutation and another. So there are so many challenges in developing therapies for Duchenne. We've come so far in the last 20 years, but I think we're making some real strides to understanding these diseases, understanding these modalities, and really being able to drive forward effective therapies for patients.
You bring up an interesting point, Jay, with respect to data sharing, for example, especially in a way that it becomes taking the confidential information, making it non-confidential in a way such that the community can learn. Could people comment on aspects of that?
Yeah, we've done a lot. I think people have actually been there's been a lot of data sharing, and in particular, because if you think about Duchenne, while it's considered a relatively large ultra-orphan disease, it's really a small patient population overall. And the most valuable kind of data you can have is the placebo clinical trial data from companies, because they're extremely well done trials. They're, you know, the data is clean and it's good. And what the groups have been doing is we've been able to actually bring together, like we've done 2 phase 3 trials. Lilly has done a trial. BioMarin has done trial. And we've actually aggregated a lot of that placebo-controlled trial, which is incredibly valuable data that then allows you to mine information to try and define what is the best clinical endpoints that were on the trial. But it's not only like Jane was saying, it's not only in a sense, when you say what are the best clinical endpoints, which ones are the least variable, right? And what is the variability that will ultimately allow you to power the clinical trial as a consequence of that? But it's even more than that. It's also like, I think most neurodegenerative diseases are sort of Goldilocks. When the patients they're almost like, when they're early in the stage, they're very good and you don't see big changes. And when they're late in the disease, they go rapidly and most modalities won't have a real effect because, like, let's say you're looking at loss of ambulation or you're looking at changes, they're going to rapidly go. You need sort of like in the middle where there's some decline that's measurable, but it's not so rapid that that the modality won't do anything about that, affect the ultimate outcome. And that takes a very much amount of work to try and figure out what's the best patient population on top of what's the best outcome measures to be able to demonstrate that. And you needed all of that data to be able to do some of that. And so there's been a lot of mining as a consequence of that. And I think there's a lot of ways where we can use, where it has been used, and we've used it ourselves as a consequence, to be able to pick out what are the best patients, what's the best outcome measures in order to have the greatest chance of success, that if you have a drug that works, that you'll be able to see it, right? That's the hardest part in some of these diseases, because in the time frame that you're doing the experiment in.
And the points you're raising, Stuart, also suggests that this is a place where biomarkers can become important, and having the right biomarkers. And this is really a place where we're going to share with academia, because many of these biomarkers are going to be assessed in academic environment. It's a place where we may be able to actually, for the first time, modulate some of those biomarkers as we develop them. And yes, this is a bit of a forward-looking statement. We do need to develop biomarkers. We need them, and we need them validated. But I think ultimately, as much as we can move away from these highly variable endpoints that we're dependent upon today, and have much more quantitative measurements of the molecular changes and how they relate to physiology and to the phenotype, I think that's when we're going to make even greater strides in the design and interpretation of clinical trials. I guess I am a little bit Pollyanna-ish here. I admit that I'm being incredibly optimistic and forward-looking, but I think this is where we should strive to be in the very near future with many of these diseases.
It is good.
If Art is Pollyanna-ish, I am probably even more so. But one of the things we've really seen in the Duchenne community, which I think is amazing, and Stu alluded to this, is the generosity of people who've done trials, sharing that data, either through the Duchenne Regulatory Science Consortium that I used to run, or through the Collaborative Trajectory Analysis Program, bringing that data together, sharing that data, sharing analyses, working in collaboration with the regulators in the case of de-risk, of really being able to drive ahead analyses that support biomarkers and support endpoints and help us understand that variability in the population. I think the ability of this community to both share data, work together, and drive some of these analyses forward. We're not there yet. You're absolutely right, Art. We don't have all the biomarkers we need, and there are a lot of half-developed or semi-developed biomarkers that have huge promise. But if we can continue to share data and work together, we can move all of this forwards a whole lot more quickly. Now, I'm sure that makes me sound even more Pollyanna-ish. I've been sitting in the seat of trying to drive these collaborations for years, but I think it's really important to moving all of our therapies forward and getting them to patients as quickly as possible.
I would just add, seeing the amazing work that, Jane did at CPATH has moved the field forward. I mean, it's been tremendous what many of these collaborations and consortiums have done. And I would just add, so not only does it help companies develop trials that are smarter, that will truly extract the treatment effect of the modalities we're testing, but similarly, many of these collaborations and databases help us contextualize the data that we actually generate from our trials. So whether it's from the Synergy database, or if it's Imaging DMD, which has tremendous muscle MRI data across the population. So these collaborations are so important to be able to also understand: are you able to change the nature of the disease, the trajectory of the disease? And there's a tremendous amount that exists to help us understand whether it's North Star UK, Synergy, Imaging DMD, CTAP. So there's the field has moved incredibly over the last few years, over the last several years, thanks to these efforts like Jane is alluding to and that she's led in the past.
Can I add something, Rich? So in terms coming from an academic perspective, I mean, for us, we go to meetings and we really enjoy sharing our new data with everybody. But what I see in the DMD field is that there is a collaboration between companies and academia in ways that I've never seen with any of my other research efforts. And added on top of that are the parents and the advocacy groups who really play a big role in getting the industry and academia together at a lot of the meetings that they organize. So I think that in terms of collaboration, I think I haven't seen anything like that before. So the DMD world is really unique in that aspect.
Yeah, so we'll come back to about patient advocacy groups in just a moment. But I just wanted to finish up our conversation around drug development challenges. And do we have regulatory approval? Do we have regulatory buy-in to all the biomarkers and all the markers that you're generating as your endpoints?
So our friends at the regulatory agencies are obviously and clearly defined by data. So do we have all the support from all the worldwide regulatory agencies on all of these? Absolutely not. And that's probably reflected by the data we have available, that we have some support for all of them. We do not have definitive proof that any of the biomarkers we have, including those that have been used for accelerated endpoints, will really change disease. It's a good hypothesis. We have some data, things like MRI, as Ash was mentioning too earlier, we actually have quite a lot of data. And the regulators are following the science just as well as much in detail as we are, trying to understand how these biomarkers reflect clinical endpoints, how they reflect patient experience, which may be another thing entirely. We're all following this. The regulators are all following this. I think we're in it together, and we're all trying to understand this disease at the same time in real time while we're developing drugs for it. I'm sure my colleagues have more to say about that.
Yeah, let me amplify what Jane just said, and that is, the regulatory authorities are extraordinarily interested. They understand that these are terrible diseases that we're dealing with, and they have really done their best to facilitate and create collaborations with the corporate interests, not necessarily corporate interests, with the interests of the patients in mind, and to create what is an environment where it is more of a give and take. The agencies will provide information as to what they're going to need in order to really feel convinced. And I think making sure that we keep the regulatory groups involved as we develop these drugs is extraordinarily important for us, and view them rather like I did in my youth as antagonists. They are now really partners for us. And so between the academic collaborations, the collaborations we have with the patient advocacy groups and the regulatory authorities. And I think all of these are key parameters that we need to keep in mind as we're developing these drugs. And really, although we think of them as regulatory hurdles, it's really convincing the regulators and convincing the public at large that we have therapeutics that work and that are safe. And that's really the goal. The goal is to get the drugs to the patients as quickly as we can, and I think the regulators share that with us.
I think that's all true. I think everyone's working on the same side. The tricky part of biomarkers is that they're supposed to reasonably predict clinical benefit, right? And so that's always been and that's what everyone's working towards. But it's almost like a chicken and egg problem in some ways, right? Where how do you know something shows clinical benefit when you're measuring a biomarker? And so it's always difficult. Like, I think a great example is in the spinal muscular atrophy field, right? It's the reduction of SMN protein that leads to that disease. And so most recently, we've done trials where we using a small molecule drug where you see increased levels as a biomarker in the blood, and then you saw improvement in terms of clinical benefits. So you've linked the biomarker to the clinical outcome or manifestation of that, right? And so that's a clear marker now. Other people can use SMN levels. So it's actually a nice, so the difficulty in a lot of the neurodegenerative diseases that we've had so far is that connection has not been easy, right? And that's in part because we don't have great clinical markers and we don't have great biomarkers and where we've been able yet to connect that. And so what the field needs to do is to work hard to try and get that. So it's variable in terms of what the regulators think. Like if you think that the US has, for better or for worse, have now used dystrophin as a biomarker that's an approval point for accelerated approval, where you then have to show clinical benefit. The rest of the community outside of the US has not yet taken that up as a viable approach for approving drugs yet. So you need to do clinical benefit. So it's a little bit all over the place in terms of how you can use biomarkers versus clinical endpoints.
I would just add a little bit, not too much more to add. I mean, you know, in my experience, the regulatory bodies, certainly in the US and Europe, they've been very supportive. I mean, they welcome the dialogue. They want to help make sure that the industry is conducting trials that will help them understand the benefit risk of a product. Yes, we have the accelerated approval pathway in the US, and there's not something like that exists in Europe for Duchenne yet. But nevertheless, ex-US regulatory authorities are still very open to dialogue about how to get these therapies to market. And it does come down to data. It does come down to benefit risk, as it always has. And so, you know, I just find, and they are personally invested in the sense of, you know, the FDA members sitting down with CPATH and trying to help guide CPATH and have a dialogue with CPATH or other bodies. And so there is a tremendous amount of passion and support from regulators for you know, for Duchenne, for dystrophinopathies, for other diseases, of course. And so it's been really gratifying to see that grow over time.
Thank you. Now, one last topic on the area of challenges in drug development is that of manufacturing. I mean, you know, Stu's experiences have been in the small molecule space for sure. But as we get to these more complex, let's say biologically driven mechanisms, do we have manufacturing issues that we're going to have to contend with? Maybe if anyone tackle that question, I'd be very receptive to that.
Sure, I can kick it off. One of the advantages that we have with the current technologies that we're using is that we're building on multiple decades of experience synthesizing monoclonal antibodies, and we're taking advantage of now decades of experience making oligonucleotides like the PMOs or some of the sRNAs that we're using from others. So we're taking two relatively well-known technologies and the known safety profiles of those technologies and building upon that. So again, the manufacturing issues, while they are not small, at least for the technology that we're proposing, these are technologies that have been well established and well utilized in the pharmaceutical industry up till now. So again, we've tried to minimize the technologic risk and the manufacturing risk by using well-trodden pathways of oligonucleotide therapeutics and full-length monoclonal antibodies.
Okay, thank you.
Yeah,
okay.
I would just say, yeah, just a quick comment. Not much yet. It's not a trivial matter to produce, you know, in our case, a Fab drug conjugate. But to Art's point, the technologies existed, and we really need to be efficient in being able to manufacture these compounds. And I think, you know, it's that efficiency that you continue to optimize, have greater yields. But it is, you know, there is technology that's existed for us to be able to lean on to have that confidence that we can manufacture safe drugs with enough efficiency. And so we're, you know, there's a lot that we can lean on from previous learnings, which is important.
So let's take a look at
the other one that's a little more tricky is in the gene therapy manufacturing. Mm-hmm. That one is, first of all, it's the quantities required are relatively large. The manufacturing is actually difficult. The regulatory environment is changing over time as more and more of them come through. And so that right now, that's somewhat because it's a nascent field in terms of real treatments, that the manufacturing of that is both being sort of defined more. But that is something that, well, there's no one represented here on the gene therapy, is something that everyone is looking at, and the difficulties of we do gene therapy at our company, and so we have a manufacturing facility. So I'm really quite aware of just the difficulties of manufacturing large quantities of that material. But that will improve over time as well.
Right. So that kind of was going to lead me into my next question: is where does gene therapy fit in this whole, all the therapeutic regimens that we have, or optionalities that we have, or will have, hopefully going forward into the treatment of Duchenne's?
I think it's got a huge amount of promise in the future. And we're in early days of gene therapy. The first gene therapies have been in the clinic for a little while now. And the concept of being able to replace a missing protein is intuitively fabulous, rather like Rhonda's approach of being able to fix the gene in place is fabulous. But as Stu just said, this is relatively early stage technology, and there's still a lot we need to learn about gene therapies. I think what's exciting is the potential to have a whole pharmacy of different drugs that, depending what stage of disease you are, what mutation you have, what your risk tolerance is, you might be able to choose from all of these different modalities, and having a deep pipeline in Duchenne. And Rhonda, working CRISPR, I'm sure you have thoughts about the other gene therapies as well.
Right. So, I mean, the gene therapy, I think that you're speaking about, is putting in a really truncated microdystrophin in. And in terms of its function, there's so many questions about it. So the type of, gene editing that we're doing is to, again, make these little RNA, these guide RNAs, which tell the CRISPR where to go in and make the modification so that the gene is repaired in such a way that you'll be then making some dystrophin, albeit it might be also a truncated form, but not to the same extent of truncation as they have with the microdystrophin. So it is, working on those guides to make sure that you tell the CRISPR where to go in the genome. That is key, and then delivering it. So those are the two areas that are under heavy, experimental design right now.
The issues that we have with delivering the gene therapy is really based on viral load issues, right? If I'm not mistaken.
Yeah. They're on to the 10 to the 14th per kilogram of patient type loads, which are relatively large, not large load. And the reason is people are trying to get to all muscles within the cell, so that and that's sort of been one of the major features, is because somehow you need to tolerize the kids in order to be able to put that sufficient amount into them, and that's been their biggest issues in terms of when you've seen trials go on hold, was often because of consequence of that. So, but I think that's a matter of being more efficient and knowing how to target better, and also be able to, and therefore be able to use less viral loads as a consequence of that.
Right.
There's going to be room for lots of different modalities.
Yes.
And all of these modalities should be complementary, and that you may, at one stage of a patient's journey, want to use gene therapy. Other places you want to use pharmacologic interventions. Other places you want to small molecule pharmacologic interventions. So I think we tend to think in terms of competition, but in reality, these are choices that the patients will have in the future, and that these choices may actually ultimately lead to better overall improvement as we can manage this disease over its natural history. And that's really one of the key.
I think there's companies that are investing in understanding how the academic institutions and how these modalities fit together, how an exon skipping modality can fit together either sequentially, before or after, or in combination with a gene transfer therapy. I think we all hope, and I certainly expect, that there's going to be sort of a number of choices for patients and families. So if someone has a pre-existing antibody pre-existing antibodies to the vector, well, there will be a number of other choices, hopefully, for that patient. If redosing isn't possible for a few years, right? Or it just may make sense to give exon skipping drugs, chronically and apply a gene therapy. So there's a lot of investment, a lot of research going on, and I can't wait to have this, same panel conversation, soon, next year or the year after, and kind of see where we're at with our crystal balls.
Ron, I think
we're spending time also trying to figure out how to use less virus, and like increasing the amount of RNA, the guide RNA that's being made is one of the tricks that we see with our preclinical studies that makes a big difference, and you're able to come down in the viral load.
Well, the other thing also is that the polypharmacies could be required, not only because of trying the precision medicine that we're talking about here, but you have to reduce inflammation in order to get many of these things to work. In the absence of that, regulation, transcription, protein synthesis are far lower in cells where there's an inflammatory milieu. There's also the notion of, as kids get older, and really, if you think about it, by 7 years old, they're somewhere between 50 and 70% of the muscle is gone. You need to have muscle regeneration. There might be ways in which drugs or other ways where we induce muscle growth. So on top of getting precision medicine on bringing dystrophin in, we're going to need to get rid of the inflammation and increase growth of muscle cells. So that's where you can see that, and no one drug will necessarily do all of that, right? A precision medicine isn't getting rid of inflammation. It's not also causing increased muscle growth. And so that it's good, you think about almost like oncology, right? There's going to be multiple therapies depending on what the needs are of each patient. And that could very much depend on the age in which you get to treat the patient as well.
Right, I agree. I think one of the keys will be to treat early if you can. So you have diagnose early and then treat early.
The way we approach this early treatment, I guess in principle might be different than simply going after dystrophin, for example. There might be other targets that we may be thinking of, right? Besides dystrophin, if anyone would like to comment on that.
Well, it's a monogenetic disorder.
Right.
So if you could replace the dystrophin, if you could also increase the concentration of utrophin in cells versus dystrophin, you certainly, if there was a means to be able to do that, you could probably come up with another way, which is almost a gene replacement, if you can turn on the transcription of utrophin in cells. So there's other ways that you could do it, but dystrophin's a key player right now.
Right.
I agree with Stuart.
Okay. This is a little off topic, but in terms of earlier diagnosis, we really need to move towards newborn screening. It's essential that we start to, as cross-industry, cross-government, cross academia, push for newborn screening so that the average age of diagnosis, which is like 4 or 5 in the U.S., we need to push it way earlier. We know that there are deficits that are seen as early as 2 years of age, but muscle is being lost. Time is muscle. So to be able to treat as early as possible with the most powerful medications is absolutely critical. And it's really newborn screening that's going to get us there.
Terrific. Well, let's just shift gears for a little while and talk about collaborations and patient advocacy. How important are these in terms of finding these new drugs and the new directions that we might undertake? Start with Jane.
Sure, and as the panel knows, I have some bias, having worked for and with patient advocacy for most groups for most of my career. I actually think it's absolutely critical that companies work with patient advocacy groups and with patients and their families all the way through. We need to understand the communities we're working for. We need to understand what they want from our therapies, how they can best tolerate clinical trials to get effective therapies that are useful to them, to those patients. And patient advocacy groups are our partners through all of this. They are the neutral conveners that have pulled together so many of these pre-competitive space collaborations together, whether they're working on biomarkers or outcome measures or working with the regulators to understand the disease. even at the academic level, as Rhonda mentioned earlier, convening meetings to bring academics and companies together, bringing clinicians into those groups, and making the community as a whole communicate all the way through from basic discovery to bringing drugs on the market to patients. So way back when I was working at MDA and we worked with Stu and PTC on some of the very, very early studies, it was very clear that the company had something, we could help them do it, and it happened. At least it's to the degree that we could with the technologies at the time. And mistakes were made along the way. We all make mistakes, but the community as a whole can do a lot more than any of us individually. And the patient advocacy groups are really the linchpins to pulling everyone together, to making sure the patient voice is heard, the companies know what they're doing for the right reasons, and how we can all work together to make it happen as quickly as possible. And then I'll get off my soapbox and let my fellow panelists who have seen it from the other side also talk.
Well, I'd say, as Jane said, we started in probably 2003 or 4, and we had a drug for a nonsense mutation that could be used, and we had calculated at the time probably 2,500 diseases where about 15% of patients have their disease due to a nonsense mutation. And the interesting thing there is, once we thought we had a drug, I walked around to many and found a lot of advocacy groups. And it was interesting to find, we started with Duchenne in part because they had their whole act together, them and the CF Foundation at the time, where they were trying to get physicians together. There was an animal model that you could study. They were interested in natural history. They were incredibly passionate about it. You can meet parents. And so in a way, we started with the groups since 2004 or 5. So we actually grew up with them, right? And we grew, and we learned from them. They learned from us of what it's like to bring a drug, an idea into the clinic, into getting to patients. So I thought it was a tremendous, and I really learned then. And it was great for the company too, because it transitioned the company to realizing the passion is the patient, not just the science, right? So when you're a little company at first, it's all about the science. Then you go here and you meet everyone, you realize that if you could change the course of how their life is, that's a big deal. And you give them hope. And so there's a lot, you get a lot, it's a two-way street. Not only are you trying to bring a drug to them, they're bringing the passion and power, and in a sense, they give the company a cause. And I've always said it's better to work for a cause than a company. And so everyone was, it was really powerful as a consequence. So we now work with hundreds of patient advocacy groups across, and it's always valuable to us.
Yeah, so well said by Jane and Stuart. I think they've been tremendous educators, for us. Like, what are we targeting? And they've really been very clear in what we need to target. And so that has been a huge educational experience, I think, for many of us, certainly for me. I also have seen, right, the advocacy organizations such as, PPMD or CureToShins investing in technologies coming out of academia, or investing in private companies, and really putting time and money and resources and effort and advice behind a number of technologies to be able to advance them, and may the best technologies get out there and get drugs on the market. And it's been absolutely tremendous. And then, for us internally, we've had patient advisory boards, reached out to so many different patient leaders to gain advice in our development program. And it's just, we're so grateful for that voice that they provide, that time and effort and thought they provide to be able to make sure that we are, going down the right track and incorporating what they think is needed in the clinical development program.
So this has been a great set of discussions. We got down to the last couple of minutes. So I think I'd like to wrap up by asking the panelists, what do you say to the world who are working either in Duchenne or outside Duchenne about the prospects of success? What's around the corner for this disease and disorder? So let's start with Rhonda.
Okay, great. I think the future is bright for Duchenne. And I believe so that CRISPR really offers them a new approach. Our idea is a one and done. You go in there, you fix the mutation, and then you're able to restore dystrophin. And I know that's a little bit of fantasy, but I believe that we'll be able to overcome the challenge of delivery of the guides. We spend a lot of time working out the guides and making sure we have the right ones to go in and change the mutation and correct it. I believe we'll be able to partner with different like engineering team, production team, to be able to get the CRISPR components into the muscle, into the heart cells, and hopefully also into brain, and be able to correct the disease. And the key will be, as Ash said, early detection, and then we'll be able to deliver the components, because once the muscle is atrophied, then we don't make muscle. All we do is, if we can make the dystrophin, we can keep the muscle and functional. So I believe the future is very bright for Duchenne and CRISPR.
Thank you so much, Rhonda. Stu, you're next on my screen, so we'll go to you.
I see through the lens of when we began for where we are now. We were like the first, and now I see a plethora of potential treatments in many different disorders. So, and I'm a shots on guy, shots on goal sort of guy. The more shots you have, the more likelihood there's going to be success. And I think, people are thinking quite broadly in terms of, fixing the inflammatory, fixing the dystrophin, fixing the regeneration, so that hopefully, 10 years is not such a long time in drug discovery, but in that area, hopefully we're not that far off from saying we're treating all aspects of the disease. That will be good, not only for DMD kids, but if we could get muscle, it'd be good for all of the neuromuscular disorders. So I'm hopeful that what comes out of here is going to benefit the DMD kids, but also will result in helping a broad set of patients with different neuromuscular disorders.
Thank you. Ash, some closing thoughts.
Yeah, I think, what I expect, what I hope and expect is similar. That what hopefully what folks here are hearing here is many different institutions and companies looking to develop treatments that are going to transform lives. We're going to change the nature of this, of the progression of Duchenne. It's not going to be just slowing down progression, which is incredibly important, but hopefully stopping progression, addressing cardiopulmonary issues, maybe even reversing, who knows? But it's really, incredible to see that with these technologies that we're talking about and others that aren't represented here, everybody's really aiming high and trying to transform the treatments that are out there.
Thank you. All right.
So it's difficult to build on what was said, but I'll give it a shot. And that is, we're at the cusp of the biological revolution, and you're hearing that we're going from modulating RNA and how RNA is processed, all the way to Rhonda, who's actually going to alter the genome. And I think we're really in the process of learning how to use all these tools in the best possible way, which is a brighter future for these boys. But I think the goal here is that we need to get therapies to these boys now, because unfortunately 10 years in the life of a boy with DMD is a long time. It's the difference between ambulation and non-ambulation. Right. So it's our goal is to really, how can we best harness the biological revolution that's going on now and get drugs to patients as quickly as possible, and make a difference for the boys who are toddlers today, so that when they're teenagers or when they're older, they'll maintain ambulation and have a higher quality of life.
Thank you. I eloquently said. And Jane, final closing.
Well, I certainly share the optimism of the other panelists that I think we're on the verge of huge changes. In the time I've been working in Duchenne, we went from really nothing to the first treatments reaching patients, which are having some effect. And I think it's just moving faster and faster. There are more and more things in the pipeline, depending on who you are, your mutation, what stage of you are in disease. You're probably going to need different therapies. In some cases, you may be more reliant on the anti-inflammatories and small molecules. Some people may have exon skipping treatments sooner. But I think wherever you fit in that spectrum, there are going to be options for you soon. 10 years, as Stu said, is not as long in drug development as it sounds. It's a very long time in a patient's life. But I do believe we're going to start having some options. We already have some options, and we're going to have more, and they're coming faster all the time. Personalized medicine is changing things. It's evolving more quickly than we can imagine. I couldn't have imagined CRISPR at the beginning of my career, and now we're actually thinking about it as a potential treatment going into human beings. There is so much promise out there, and so long as we as a community continue to work together and develop all these different elements and arms coming together, I think we're going to get there. I've been in nonprofits and I moved into industry because I saw things that I think were really going to work. And I'm looking forward to seeing what that next 10 years looks like.
Thank you so much, Jane. Thank you, Art. Thanks, Ash, Stu, and Rhonda. Thank you so very much for your participation today. And I want to thank all the registrants who came to this panel discussion for your time and for listening. Thank you very much, everybody.
You're welcome.
Thank you.
Thank you.
30 years ago, there was little hope for DMD patients, and these discussions would have been very different. Today, with the incredible efforts of many, we can proudly say DMD is no longer untreatable. However, there's still much work to be done as we continue to look forward to a future with new therapies and better care. The big question is, how far can we go? As we continue on this journey, what possibilities lie ahead in the next 10 years for DMD patients?
I'm really excited about what's on the landscape for patients with Duchenne's muscular dystrophy over the next 10 years. The dystrophin gene is the largest gene of the body, and in the past, it was daunting to do diagnostics with our old technologies. Over the past 10 years, the cost of genetic testing has dropped 4 times and is accessible today to all our patients. In fact, we hardly have to do invasive muscle biopsies for any of our patients these days. Over the next 10 years, I hope to see accelerated development of technologies. We already have another neuromuscular disorder called spinal muscular atrophy that has gene-based treatments that are life-changing. I envisage that gene therapy to increase dystrophin production will become available. In addition, I believe that we can offer newborn screening that will revolutionize early diagnosis so as to allow patients timely access to viable treatments. One day, we may be able to treat patients before they are symptomatic and are able to help them to keep walking and achieve greater goals in functionality.
I'm a gene therapy enthusiast, and I really believe in the potential of the current generation of gene therapies. But we're in the process of evaluating just what the magnitude of effect these therapies may have. In 10 years' time, I think we'll know, and I think we'll have learned who responds very well and who responds less well. But I do hope and believe that there will be some transformational impact so that the outlook for these young boys at diagnosis is less dire. I think cure is a very strong word, and I don't think any of us are expecting the current generation of gene therapies to deliver that. But if it can change the course of disease and delay progression of disease and allow more time for the identification of additional therapies, or to be able to redose these therapies, or whatever it is, that in 10 years' time we'll have a much better handle on how to optimize this generation of therapies, and there may be others coming up behind. But
大家好，我是北京协和医院神经科的戴毅医生。中国作为世界上人口最多、拥有 DMD 患者最多的国家，一直热切期盼着未来10年的治疗突破。首先，针对病因的基因治疗 将多点开花。ASO 类剪切调节药物、基因替代治疗、基因编辑等都将齐头并进。面临的难点包括肌肉细胞数量巨大、载体的肌肉靶向性、突破血肌屏障、AAV 天然抗体的处理以及再次基因治疗面临的风险等。其次，其他针对 DMD 病理生理的治疗药物也将迎来突破，如抗纤维化、抗氧化以及更少副作用的温和激素都值得期待。另外，针对骨骼肌和心肌的细胞治疗也是重要的发展方向。最后，评价新兴药物的手段也将推陈出新，利用最新的可穿戴设备、远程评估和监控以及新兴的生物标志物，都将使药物疗效的评价更加精准和客观。
DMD 从无药可治到激素的干预，再到当今多种药物的上市，医学技术的进步彻底改变了 DMD 的医学史。中国是 DMD 罹患人数最多的国家之一。在诊断方面，我们发现仍有1%的 DMD 患者在 DNA 的水平上没有找到他们的突变位点。另外，在 DMD 孩子运动疾病进展的过程当中，我们还没有完全明确哪些参数能预知孩子的病程进展的速度。基因治疗从基础研究到转化医学的过程，还有许多未知的挑战和问题。这些问题我们需要在未来的10年内把它解决，但是解决这些问题需要多方的合作。借此机会，我们呼吁加强国际间的交流合作，共同探索 DMD 存在的各种各样的问题，为提高 DMD 的诊治水平而努力。
So I think I'm very excited to be in an era where we can transduce genes into humans. That's spectacular. I think it creates this unbelievable opportunity that we will have humans who've received gene therapy in a heterogeneous fashion, some cells being treated, others not, and we ought to be vigorously studying that in humans with biopsies and serial biopsies and watching that over time. And I think we're going to have a spectacular revolution of understanding what muscle looks like and its plasticity, which none of us know how plastic muscle really is in a disease like Duchenne.
I think in 10 years, every state is doing screening and every affected child is identified in the first few weeks of life and directly passed to the hands of experienced clinicians where they can take advantage of therapies which 10 years from now we will know what the right cocktail is and when to start it, and they will have the best possible outcome from that.
For me, I feel like, since my parents started CureToShins, almost like 20 years ago now, and meeting with scientists then who were just starting to look at Duchenne muscular dystrophy in the mouse model, and to where we are today. That progress has been incredible, and I'm looking forward to the progress of the next 10 years where someone can go into their specialist, their doctor, and anyone, despite where they're from, what country, etc., what status they're at, that they can have answers from their doctors, and that I think families will have hope, and that they will understand that their son's life isn't over, that it's just beginning, and because of the treatments that are available for everyone, everyone can have that sense of hope and have that sense that they can move forward despite having Duchenne muscular dystrophy.
Optimism, perseverance, collaboration, care. Those are the keywords we have heard again and again in today's discussion. And all are powerful weapons to overcome rare diseases such as DMD. By working together, we're strongly in the face of challenges that remain ahead, and we look forward towards the fruits of today's discussion. As we close today's event, I would like to thank our distinguished speakers for your valuable perspectives. and express our gratitude to PPMD, CureToShins, and many global partners for your wonderful support. And to the audience, thank you for joining us. At WuXi AppTec, we all believe in a future where every drug can be made and every disease can be treated. With over 7,000 rare diseases and only 5% with available treatment, no question, that future is only possible when every one of us work closely together. Thank you again for joining today's discussion, and see you at the next episode of our Rare Disease webinar series.